Our final talk of the session is Dr. Souptik Barua from Rice University, who will be speaking on diabetes management in underserved communities, data-driven insights from continuous glucose monitoring.
All right, thanks, Eric. Hope everyone can hear me. My name is Souptik Barua. I'm a postdoctoral researcher at Rice, and today I'm going to talk about our work in deriving data-driven insights from continuous glucose monitoring and how that can profoundly impact diabetes management, specifically in underserved communities. In this talk, I will balance both talking about the data science part of it, but also the actual disease and the effect on the community. Again, I'm glad Marcia went before me because she covered a lot of concepts that is relevant to this research. And so just to reiterate, diabetes is at an epidemic level in the United States, leading to several different complications, including heart disease, which is the number one cause of death in the United States. And an overwhelming majority of diabetes cases is type 2 diabetes. And so in my talk today, a lot of the focus will be on type 2 diabetes. The first main problem that this research of which I'm a part of tries to address is the fact that diabetes is inequitable. So it does not affect everyone equally. And there are certain groups which suffer a disproportionate burden of the disease. As you can see in this figure, certain racial and ethnic minority groups have much higher diabetes incidence rates, for example. And when we think of inequity, one thing that, as I've been learning about this research, is that the inequity comes a lot from access. So whether that is a physical access to a hospital, socioeconomic access to a healthy lifestyle, and also access problems to actual information and knowledge about diabetes in those communities which suffer this disproportionate burden. So that's the first key problem. The second key problem that was there on the first slide when I pulled it up is that 1 in 5 people actually do not know they have diabetes. So that's a big problem because eventually when they do go into the hospital, they are at a much more severe stage of the disease. But also there is an opportunity there. And can we actually detect the disease early somehow? And that can have a profound benefit on health outcomes. Okay, so early detection can lead to lower risk of complications and all those lower burden on the healthcare system. Okay, and as a potential solution, one small piece of the puzzle that I'm going to talk about today is a continuous glucose monitor. Now, Marcia before talked about continuous glucose monitoring, so I won't go into a lot of detail. It's a tiny sensor that sits just under your skin, and it keeps recording your glucose level somewhere between every 5 to 15 minutes, and then sends the readings back to a receiver like a smartphone. However, most of the research in CGMs has been in type 1 diabetes, and further, it has mostly been in white populations with type 1 diabetes. There is very limited study of CGM use in type 2 diabetes in minority communities and in underserved communities. That's virtually non-existent. And that's one gap that the research I'm going to talk about is planning to address. The second gap, which hopefully if we address can really bring CGM as a contender in type 2 diabetes, is a data science challenge, right? Which is that while the CGM continuously records data every 5 or 15 minutes, so there's a huge amount of rich temporal data that's captured. Current established or recommended metrics for CGM analysis that clinicians use are summary metrics like average glucose, how much time is spent within a certain range. So these metrics tend to smooth out much more finer variations in the data that can be potentially prognostic about some aspect of diabetes, such as progression, right? So as an example at the bottom here, the shape of how your glucose spikes after you eat can potentially tell us something about your diabetes risk. But the current established markers do not directly capture that information. Okay, so that's the setup of the problem. Can we use continuous glucose monitors in type 2 diabetes and specifically to help reduce this disproportionate burden of diabetes in underserved communities? As a data science researcher, my contribution comes from data driven insights, and specifically, can we find new biomarkers from data, specifically CGM data? And to do this research, we at Rice have collaborated with fantastic researchers at Sansum Diabetes Research Institute. They are very invested in addressing this inequity problem in diabetes, and they directly work with communities who are underserved, and that's the data set we have analyzed in my work. So the data I'm going to talk about comes from a study whose initial goal was to just examine if underserved, if an underserved community even accepts a continuous glucose monitor. Like, what are the thoughts around just wearing a CGM sensor? So this was initially an observational study to do that, and then a bit later we came into the picture and have tried to make some sense from data-driven modeling. So in the study, we have 119 participants, predominantly female and Hispanic Latino, underserved Hispanic Latino individuals who are recruited through community outreach. And then once they come in for the study, it's a study where the first day they just come in and have some baseline measurements taken, as you see here, including the HbA1c, which is the gold standard marker for diabetes diagnosis. And then an expert or like a lab expert puts the CGM sensor on the participants. Then they go back home and they just live their life for 2 weeks. So it's completely free living. No instructions are given. An important fact to note is that in this study, the CGMs were blinded. So there is no information feedback going back to the participants. And so there is no intervention or happening directly from the CGM. So it's just free living CGM wear for 2 weeks. Okay. Another important aspect is that not all the participants in this study were people with diabetes, but at different stages of diabetes risk. So this speaks to the problem that I mentioned, where we want to detect diabetes early. And so we hope that having this mix of participants from different diabetes risks and studying what changes can actually help us find data-driven markers to detect stuff early, right? So in this case, we have participants who are healthy but at risk of diabetes. The at-risk part comes from high BMI, and there's some other factors. People who are pre-diabetic, so that's the HbA1c range, and individuals with non-insulin treated type 2 diabetes. Okay, so these are participants who have diabetes but are not using insulin as treatment. And so what we then did was think of some hypotheses that we can test, which sort of captures this fine-grained data variation. Can we go beyond the summary CGM metrics, right? So the first hypothesis is that comes from our clinical collaborators at Sansum is, are there differences in how glucose levels behave during the night, typically when you're sleeping, versus during the daytime, right? When you're awake, you're doing stuff, you're eating, and so on. And is there a link between these relative fluctuations and your diabetes risk? Okay, so I'm going to it's not great and sort of synonym, but I'm going to use diabetes risk and HbA1c both like in place of each other sometimes. Okay, so that's the first hypothesis. And the second is when you eat, your glucose rises. Does the shape of how the glucose rises, is that connected somehow to diabetes risk as well? Okay, so in the bottom, as an example, you have the glucose profile for an individual who has diabetes, and we wanted to study these particular hypotheses closely. Um, so let's go into the results. The first hypothesis, what we did was we separated out the CGM or the glucose readings depending on the time of the day. So we have overnight readings and the rest of the day readings. And then we compute a metric, which is the time spent in the healthy range. So 70 to 140 mg per dl is the healthy range. We wanted to see the relative time spent in this healthy range during this overnight period versus the daytime period. And this is what we saw. Okay, so let me walk you through this chart. Each dot is a participant, and the color of the dot represents diabetes risk, from at risk to pre-diabetes to diabetes. And what we saw is that there seems to be a pattern in which uh, the prediabetes participants uh, tend to show much elevated glucose levels during the day, and that's why the rest of the day time in range starts to fall. And then in the diabetes participants, you see worse or elevated glucose levels throughout the day. So our work just is providing a new hypothesis to test in the future, which is that is this a pathway to diabetes progression? We call it this the south by southwest drift, because it seems like it's the rest of the day or the daytime glucose that tends to go abnormal, followed by things overnight. And why might this be important? Could be an important finding. Well, you can imagine that if an individual comes into the clinic and we give them a CGM for 2 weeks, where they lie in this 2D chart can tell us something about diabetes risk. Plus, if we can monitor them over time, how their dot moves on this graph can potentially tell us something about are they becoming worse, or are they getting better? That's that kind of information. Also, there are distinct reasons why the overnight glucose and the daytime glucose can go abnormal based on physiological understanding. And that's something also this kind of differential time analysis, time biomarker can tell us. Okay, so that's the first sort of interesting finding that we have about CGM data. The second hypothesis that we tested was, does the shape of post meal glucose response tell us something? And we specifically analyzed breakfast, because even from this kind of figure, what you can see is that breakfast is happens right after several hours of sleep, when typically not a lot of fluctuations happen, and so it's easier to sort of analyze and localize. Okay, so we first focused on breakfast, and in the future we might extend our studies to other meals like lunch and dinner. So that's the question. What does the shape of the breakfast response tell us? As a starter, we quantified the breakfast response using a small set of parameters that capture different aspects of how the glucose changes. And what we also did was aggregated these breakfast curves across different risk categories. And what we found was that if you looked at in aggregate, the breakfast curves from the diabetes group seem to show a much higher and more delayed peak compared to the other two groups. The differences between the at risk and the pre-diabetes participants are not as pronounced here, but you still see a little bit of difference. But yeah, it's not pronounced at all. So we call this the northeast drift, because we tended to see a shift in where the peak of the post-breakfast glucose spike happens in time. Okay. Again, a lot of this needs to be validated in larger cohorts, and I will talk about a few limitations. But what are the implications of this? Well, the first implication is that while we did know from prior clinical experience about the importance of your fasting glucose, or how much the glucose rises after you eat, the time it takes to reach that peak, that was identified by our analysis as an important parameter. And this also suggests in the future we can have perhaps CGMs at home and monitor our breakfast responses for 2 weeks. Can that serve as an at-home diagnostic? Also, this suggests that we can target breakfast-based interventions, like a new kind of breakfast medication or a breakfast meal, and study it, because we can identify, we have like seen these kinds of trends in the breakfast glucose response. um, so yeah, so so we have developed these two sort of biomarkers from CGM data. Obvious limitations which are there in the study is that this was an initial study, so it was free living, and we did not record information about food choices, exercise, sleep, uh, and we have information about medication, but it was only a few participants. So we really want to understand what role do these variables play. We do believe that observing 2 weeks of data really helps, because it averages out certain inter-day variations, but this needs to be studied in detail. Also, CGM accuracy may not be as high as I've actually studied in one of my papers. It is under review. And so it's important to keep that in mind when pushing a data-driven CGM biomarker. Uh, in terms of future work, like I said, we need to also see the effect of some other variables, and this is actually underway in a study with Sansum, where we are actually putting multiple wearable sensors on participants to really get a precise understanding of these other factors that affect glucose. A lot of data science challenges still need to be addressed, as well as validation on larger and more diverse cohorts. So in summary, the two key problems I wanted you guys to take away is that diabetes is inequitable with disproportionate burden on certain communities. And the second fact is that diabetes right now, we need to detect earlier so that it can profoundly improve outcomes. Continuous glucose monitors can potentially play a big role in doing that, in addressing these two challenges. And we have identified two data-driven biomarkers to really understand diabetes better and lead to better diabetes management and even prevention. Yeah, with that, I would like to stop.
Great. Thank you very much. We do have a couple questions from the audience. So the first one is, what are the barriers to studying these underserved communities?
Right. So I think as part of this research consortium called PATSUP, and I'm happy to talk more in the mixer, we do actually go out to the communities and ask these questions about what are the barriers. One barrier, obviously, is a CGM device is still pretty new. So I think what it needs is a lot of community partnerships. So not just hospitals, data scientists, and communities in isolation, but a more comprehensive, unified network. As an example, I'll give you Sansum Diabetes Research Institute has a community scientist model. So they train and recruit individuals from the community to learn about data-driven technology and then take it back. So that's one barrier, is this interaction between the community and the experts.
Sure.
Yeah, like that's, I think, the first one comes to mind.
And have you, maybe too early, but have you noticed any differences yet in the data from the underserved communities versus what's out there already, which is primarily European ancestry and maybe more affluent?
I think that's something that we still need to study more closely. I think there are a lot of variables that differ across these participants. And so to really account for them, as well as then study the glucose data, is something we want to do. But I think, yeah, this is the first of its kind study where we just are getting data from these communities for the first time, but definitely something to look at.
Sure. And one last question we have, would more patient data help with this approach?
So more data always helps in machine learning and data science. So that's so more data always helps, but we have to remember that that can be especially challenging in getting data from communities.
Sure. All right. Well, I'd like to thank you and all the other speakers. And just as